Hello, thanks for inviting me here to talk about this subject. Again, I'm Nick Burris at University of Michigan. So as a brief introduction, type B dissection, unlike its type A counterpart, is largely a chronic disease. 90–95% of people in the hands of good aortic centers will survive the acute phase, and they have a chronically dissected descending aorta that's prone to a lot of long-term complications. The most significant long-term complication is aneurysm development that occurs because of false lumen dilation, and this occurs in up to 60% of patients at about 5 years out. The mechanisms that lead to this aneurysm formation are kind of complicated, and there's a lot of things kind of competing, a lot of competing forces. You have kind of these deleterious forces that are in balance with kind of the aorta's ability to remodel or heal. You've got hemodynamic stress, kind of mechanical instability, and then stuff related to the wall actually being degraded. And this will eventually either kind of the patient will progress to an aneurysm, or some percentage of these patients will actually stay stable over time because of the favorable remodeling. Hemodynamic forces are thought to play a pretty significant role in this process, and it's actually, interestingly, kind of one of the factors that we can actually non-invasively measure with some degree of reasonable accuracy. And so that's what makes it most interesting to me. Kind of as setting up the clinical picture a bit, surgical intervention obviously is quite effective when it's employed to treat these patients. But it's really, especially endovascular repair, is going to do best long-term when it's done kind of in the subacute phase, sort of 3 to 6 months, within the first 3 to 6 months. So that actually presents an interesting challenge because you don't really want to wait for these aortas to declare themselves in terms of developing a huge aneurysm before you give them treatment if you want to optimize outcomes. So there's definitely a significant need to better predict which of these patients, kind of what the balance of these forces are and what the ultimate outcome is going to be to allow for early treatment. So when you do 4D flow in a dissected aorta, you see a lot of really complicated flow patterns. One flow pattern that kind of is pretty consistently commented on or seen by a variety of different people is retrograde flow in the false lumen. This was first kind of described back here in 2013, Chris Francois. And then this is particularly interesting to me because when you look at computational modeling studies, the degree of retrograde flow actually increases directly in proportion to the amount of inflow-outflow imbalance. So as you have excess inflow relative to outflow, you get more diastolic flow reversal, and that's shown here by this increasing from the blue to the red curves. This diastolic flow is increasing. So in some work that I presented at this meeting a couple years ago and we published in 2018, we just took we wanted to first see if this was a relevant parameter. So we looked at it and we classified patients as stable and growing, enlarging groups, and we looked at just differences in retrograde flow. Specifically, we measure retrograde flow at the dominant proximal most entry tear, and we quantify that as a regurgitant fraction. And we noticed that there was significantly elevated rates of regurgitant flow at the entry tear in the enlarging patient population. This was I don't have the mean up here, but the enlarged group was about 38%, and the stable group was about 7%. But this is very complicated. There's a lot of other anatomic factors at play, and so while this was an interesting parameter, we wanted to look at this in definitely some more depth. So the aim of the study was to investigate the ability of these variety of anatomic factors, hemodynamic factors, to independently predict false lumen growth using a multivariate analysis. So we enrolled prospectively 18 patients with descending thoracic dissections, 15 type Bs, 3 repaired type As. These patients were all subacute or chronic dissection patients. The youngest or the earliest was 6 weeks, and the oldest one was 8 years old. Almost all the studies were done with contrast. Majority of them had ferumoxytol. We have scan parameters. We select a VANC of pretty much 200 in all of our patients. Has been an approach that's worked for us so far, and we performed a pretty standard 4D flow analysis. So the primary variable that we were interested in, kind of how we define it, is this regurgitant fraction, and essentially what it is, very simplistically, is just the ratio between the inflow during systole and the outflow as measured at the proximal entry tear. So it's just a ratio. Here's a particular case where we place a 2D plane in the plane of the entry tear, so that takes a little bit of adjustment. But then you just measure the flow in and flow out as a ratio. So looking briefly at the patients, the characteristics here, average age 50, obviously almost all of them had hypertension. We had about a 3.5 on average year age of the dissection at the time of the 40 flow imaging. Fairly sizable, by entry tear size, almost 1.7 centimeter proximal entry tear size. The average growth rate averaged over this entire cohort was about 5 to 6 millimeters per year. Obviously, we had a cohort that was kind of slowly growing or stable, and then we had some rapid growers in there. Kind of lumping all the hemodynamic parameters together just to give you an idea of what the flow looks like in the true lumen versus the false lumen. The flow was on average 3 liters a minute in the true and 1.4 in the false, so definitely slower or less flow, and on average slower peak velocity flow in the false lumen. It's highly eccentric flow tends to be, and similar comparison between the entry tear and the false lumen flow parameters. So really basic analysis, just some scatter plots of some of how this aortic growth rate or the false lumen growth rate correlates with some basic parameters. We did see kind of a trend on baseline maximal aortic diameter. That's probably the strongest and most commonly reported predictive variable that's used in the literature. The false lumen ejection fraction, which I'm sorry, we've been kind of flipping terms here a bit. We're kind of rebranding the regurgitant fraction as the false lumen ejection fraction. Those are synonymous. I'm sorry for the typo there. The false lumen, this regurgitant fraction or the false lumen ejection fraction was significantly and moderately correlated with the aortic growth rate. We didn't see any relationship with the dominant entry tear size, and we saw very weak or no real relationship with the distance from the left subclavian to the entry tear, which is also a parameter that's described in the literature as being predictive. So we threw all these, in addition to some other parameters of interest, into a multivariate model to kind of tease out the individual kind of predictive value of these parameters. And there's 3 things that jumped out as significant in this multivariate model, including, again, this false lumen ejection fraction or the regurgitant fraction was a significant predictor. The baseline aortic diameter, which makes sense, that's very commonly described in these dissection patients. And then actually this entry tear distance from the left subclavian was also significant in the multivariate analysis, which again has been reported in a bunch of other clinical studies, so that at least was congruent. This was a fairly, the model was almost 0.8 adjusted R-square, so it does a very good job in predicting the variability in aortic growth rate. So this is just to kind of summarize, to kind of wrap up. This is just one recent case to give you a sense of how we could potentially employ this. This is a 63-year-old guy who developed a type B dissection very recently in May 31st, 2019. He came back for his 2 to 3 month follow-up scan. He had grown from 51 to 57 millimeters maximally at the distal arch. We performed at 40 flow on the day of his follow-up clinic visit. Hopefully this will play. So when you look at the proximal tear here, you can very clearly see this biphasic flow. You have a big systolic jet in and a significant jet going in the opposite direction during diastole. He had a very simplistic anatomy. He had one entry tear and only one very small, it's down here, re-entry tear at the level of the renals. This is about 5 millimeters in size versus the proximal tear, which was 22 millimeters in size. The regurgitant fraction here was 76% when we measured it in the plane of the proximal tear. The net flows at these 2, inflow and outflow, were almost balanced, but a lot of that flow was leaving the false lumen retrograde through the proximal tear because of that outflow obstruction. So this guy is going to have some type of an operation at some point based on how he's behaving, and our surgeons are actually going to potentially perform a fenestration. They're going to open up this tear distally with a balloon to see if they can actually equilibrate the pressures a little bit. So in summary, false lumen regurgitant fraction is independently predictive of aortic growth rate in patients with subacute and chronic dissections. There's several advantages to this parameter, I think. It's intuitive. It's relatively simple. As far as 40 flow parameters go, it's probably pretty easy to measure. It represents this imbalance of the inflow and outflow, which is an approximate surrogate of false lumen pressurization. It's a ratio of flow volume, so it's relatively robust to measurement error, sequence specific parameters. And I think because of its ability to hopefully predict growth of the false lumen chronically, there's an opportunity to perform this at a time point where it could actually affect clinical and surgical decision making. We also, again, redemonstrated that the proximal entry tear location relative to the subclavian and the maximal diameter were predictors of growth, as has been previously reported. And our future directions, we're going to continue to grow this cohort. 18 is interesting, but we need to see larger numbers to validate this. We really need to move towards the acute and subacute period where clinical decisions are being made rather than these chronic dissections. And we hope to correlate the 40 flow parameters with other clinical outcomes other than just the growth rate. But that's where we're at. Happy to take any questions.